the connection to China, which is not so easy. And therefore, I would say, good morning, Guohua. Can you hear us? No, we can't hear you. Please put
now you can hear me?
Now we can hear you. How are you?
Okay, perfect. Sven, how are you?
Are you fine?
Oh, perfect.
Everything okay in China?
Now it's okay. Maybe next year not too
now
good.
your task is to give a presentation. What are you talking about?
I will talk about the SMP for pediatric renal stone. This is semi-live video.
Okay, the auditorium is listening. You can start your presentation.
Perfect. Thank you, Sven. Wait a moment, I share screen. Okay. Okay. Dear Sven, dear Par, and dear faculties, and good morning in Morocco, afternoon in China. We'll talk about super mini PCNL for management complex pediatric renal stone. I'm Zeng from China. And actually, super mini PCNL for pediatric renal stone. This is perfect. First, I talk about this patient information. Boy, 11 years old, violet stick-horn stone. I think this is stone not too hard, and this is pre-operative CT scan. You see, this is bilateral renal stone, full stick-horn renal stone. I think this is 16 stone. This is instruments for SMP. SMP is two types. SMP and the ESMP, you see this is disposable, this is reusable. Reusable is metal, disposable is plastic. Okay, this is SMP, this is double layer sheath, and the reflectoscope is 18 French and with 3.3 from walking channel, and the irrigation is from sheath, not for scope. And then solve this not enough irrigation, and this 18 French suction sheath. This is a single layer sheath, and the working channel of the scope is 6 French, and the irrigation is from scope. Because this is enough space for irrigation, it's only for more than 3 centimeters renal stone. For this patient position, we talk, this patient position is prone. Usually in our department, more than 19% patient position, prone position is split leg position. Sometimes you can do flexible. And the first is 5 French urethral catheter is placed. And then for this pediatric, I will put a Follis catheter. The first make a puncture biaxial sounding guidance. I would like to make a puncture needle guide. Of course, I can do freehand. Freehand is okay, very easy. Maybe sometimes you can come to my department. I can tell you how to do. For this, you see, you must switch the probe, and then you can find the middle posterior calyx. I think this is middle posterior calyx for this. Not this, and very easy. And this line is online this calyx, and then you can make a puncture. I think you can get a target maybe 5 seconds, very fast. Of course, sometimes you friend hand puncture, maybe Norincoff is long. Maybe for this is very short. I must check target is correct or not under X-ray. You see, under X-ray, this is post middle calyx, and then inject saline from urethral catheter, and you see this urine is come out of a puncture needle. But I must inject a few contrast and inject and count this the puncture needle is inside or outside in correct system. You see, it's low contrast extrovation means it's inside. Then in short, I think this sensor, Boston sensor guide wire. I like this guide wire. The guide wire tip is flexible and is not for perforation. And you see, every time this is no space for guide wire down to the ureter. This is okay. It's so-called in correct. It's okay. And then make a dilation. The first dilation dilator is 14 French, and the second is 16 French, and the last one is 18 French. This is suction sheath. This is one layer sheath. You see, this is one layer sheath because for this patient, stone size is more than 3 centimeters. I will use SMP to do this operation. Okay, and then make a dilation. I must do it in under fluoroscope guidance because under pediatric sound it's very, very difficult to do it. And then I must check position of sheath endoscopy way. I think this is not too deep. Then I can make a dilation again and advance maybe 1 or 2 centimeters. Maybe I think he's going to collect the system. She's must check again under endoscopy view. You see, it's little maybe. I can circle. I can advance this sheath around this scope. This scope is 12. Left scope is 5 French, and the working channel is 6 French. You see, I can see stone. I think this is 16 stone for this pediatric, for this boys, and then connect this handle. This handle with handle connected aspiration suction machine, and then you can do it. For this patient, I will use pneumatic litho chips for break a stone. You see, this pneumatic probe is 5. I think it's 5. No, not 5. It's 5. It's 5 French. 5 French, and I think this probe litho chips is really economic, not to cost. Sometimes in China, not every hospital can buy laser machine. But now, too many Chinese laser machine is come out, and then I think its price is down. Maybe small hospital can buy formulator machine. But I like use plastic. You like use pneumatic litho chips. It's powerful and very fast. You see, I can break this stone very fast. I like it because 20 years ago I used this. I used it to do this with pneumatic. You see, it's very fast. I think I remove this middle calyx stone and passed infundibulum of middle calyx and they go into the pelvis. I think this pelvis stone is a bigger one. This pelvis stone, and then I can break into some pieces less than 3 millimeters, and then I can suction out really fast. I think it's very fast. I think you see, I can see this ureter catheter. Then I think this is pelvis. Very fast. Is pelvis is is big stone. Of course, you can use laser. You can use laser lithotrips. It's okay, no problem. Sometimes I use laser lithotrips. I use laser fiber is 550 micron, and always fragmentation. Laser setting is fragmentation. Usually use 40 watts, 2 joules, and 20 hertz. But for this patient, I don't like, because I'm afraid of hitting, hemorrhage, injury. Sometimes this is for pediatric, maybe sometimes irrigation not enough, maybe tempo is very high, maybe caused some infundibulum infundibulum stricture, and I am very be careful. But this is very small clexy stone in the clexy, and now I can go into low pole and check this different calyx stone is clear or not, and I think this is go to low pole, and then this is pelvis, and then I can check with different calyx, low pole, upper pole, pelvis, and check stone left a lot with X-ray. You see, this is very small stone in the low pole. I make puncture again. Of course, you can do flexible, you can do shockwave, it's okay. But for me, I like to remove all stone in one session. I always remember excavatory, good patient doctor must remove every stone fragment. Of course, patient safety is the first. And for this, I make a dilation with PLVCs without suction. This regularly sheaths. I will compare suction sheaths and without suction sheaths, some different remove stone fragment. Always use, you see, well, without suction, you can remove stone. It's okay with, it's okay. Sometimes not effective. Stone is inside to sheath, and then go into the cavity like this. This is okay. The first, you see, the first stone fragment is okay. Like this is inside and down and up, down and up. Is waste time. So with suction is one time remove stone fragment. Now I think it's no stone, and then I check. You see, this is 18 French sheaths without suction and without suction. For this pediatric, I will put a digit stand. You see, put a digit stand, and because I must be careful this pediatric relationship children. And then I check again this position of digit stand. You must check digit stand is going to the blood. This is really important. Sometimes it's not in blood. Maybe you remove digit stand is very difficult. For this patient, you see no stone left is 2 punctures and tubules and day surgery. Because operation time is very short, 15 minutes, and the HB is really slow favor. So SMP and the ESMP can manage all kind of stone. Less than 3 centimeters is SMP, more than 3 centimeters stones ESMP, and then they can down to the pressure and they shorten the operation time. Thank you, attention.
Yes. Thank you very much, Guohua. Just wait a few moments. We are going to look for any questions from the auditorium. Just a moment. Are there
Okay.
any questions? Yes, please. A microphone, please. Just a moment, please.
Okay, okay.
Thank you so much for the excellent presentation. Please, I want to ask that does combined irrigation and suctioning in the same system pose challenges with vision? With this
I just want to repeat it for you, Guohua. Please, could you comment on the combination of active suction and active irrigation? Is this safe?
Okay, I think with suction, I think it's safe because with suction you can down to the pressure and you can remove stone fragment very fast. Sometimes you must pay attention suction pressure and the irrigation pressure. Sometimes I think it's irrigation pressure must more than maybe 16 and 15 millimeter mercury different because it's more than suction pressure is more than irrigation pressure, maybe is space collecting system is space, no space for your operation. This is very important. But sometimes is patient is a little bleeding, maybe you will suction, maybe it's bleeding is more. So you must be careful, So for PCNA, for PCN procedures, you do standard PCNA, so traditional mini PCNA, bleeding is a headache problem. I think so. Sven?
Yes, we understood very well. Are there any other questions? Just a moment, Guohua.
Okay.
The session is dealing with complex stones, and you showed a very large stone. My question is, do you think it is necessary to add RIRS? Is it necessary to do a flexible uteroscopy in the same patient at the same time?
I think for this patient, maybe it's almost 6 centimeters for RRS flexible uterus. I think it's very good because you must remove this stone, maybe multiple, maybe at least 3 sessions, 3 stages. But for PCNA, maybe 1 session is remove stone. But for this pediatric little stone, you must do at least 3 operations. The first, you must put a DJ stand, dilate the ureter, yes. And then maybe 2 weeks, you can do flexible your stop. And the last, you must remove the DJ stand, the patient have any seizures. I think not good for flexible uroscope. I like to use PCM procedures. But sometimes you can combine it. I think you combine it is okay. Combine it is okay. Sometimes I think combine it is okay because you remove the most of little stone and then no post stone left. You can try combine it. But sometimes it's no post stone angle is very acute. Maybe sometimes it's difficult. I agree.
Okay, may I ask you, Guohua, how long is the patient staying in the hospital? When is he going to be discharged?
For this children, maybe 1 night. It's 1 night because the tubule is so 1 night patient no fever and no pain, and then the next day and the patient can discharge. I think so.
Okay. Now we have a look at the auditorium, whether there are further questions. Are there any other questions to China? Guohua, is it
Yes.
possible to tell us if you are doing tubeless PCNL in all cases, or are you performing tubeless PCNL only in rare cases? All
Not
cases?
Please, Sven.
The question is the tubeless PCNL your routine surgery, or is it an exception? Do you always perform tubeless PCNL?
No, not all patient for tubeless. Sometimes this you must pay attention to indication for tubeless. For tubeless, I think is no bleeding and the low stone left and the low collecting system population. You must be careful this indication. Sometimes for stone left bleeding, maybe you can some stone left must put leafless tube for sectionization. I think it's not for my department, maybe maybe 20 or 30% is for tubeless, because come to my department, to my center, very complex real stone, not really less simple case. You've been to my department, Sven,
Okay, thank you very much. There is another question. Please give the microphone. One moment, please.
Thanks for the presentation. Just one question about the puncture.
The voice is too, you can speak loudly.
Guohua, I'm going to repeat the question later on. Just wait for 1 minute. Just wait.
Just one question about the puncture. See if you're looking to reach the stone, that's the calcium system in your ultrasonic puncture.
Okay, Guohua.
Okay, not hear anything.
Yes, the question is, how are you doing the ultrasound guided puncture? Is your aim to hit the stone, or is your aim to hit the calyceal system? You understand
Okay,
this?
This is a good question. Sometimes this is hydrophys, this is collecting dilated. Maybe I hit this calyx, but sometimes this collecting system is not dilated. It's low hydrolysis. Maybe I hit stone. This must different feeling.
What I saw is that you improved your ultrasound. You were using a new probe, which was really similar to the German one. Is this right?
Yeah, I think it's blood PK. It's Aloka.
Yes,
Aloka
this
is
is
from Germany.
Hitachi Aloka. This is the same probe that is used by Sven for 15 years now. It's the best one, isn't it?
Yeah. I think this is good machine, good ultrasound machine. I like it. You always use this machine, Aloka?
Yes.
Perfect.
Yeah, it's a perfect machine. Aloka is the best one. Yes, it's better than BK. Okay.
I think so.
Are there any other questions? There are no further questions, Guohua, which means we are going to thank you very much for your presentation. Thank you very much from China. And we are sending the best wishes from Africa and also from Europe. And we hope that we can meet in the future as soon as possible again. Okay.
I think so. I hope so. Sven,
Okay.
dear friend.
Bye bye. Bye bye.
Bye-bye. I have another video. I can continue. Sven, it's flexible.
Just a moment, please. We have
Okay.
to check.
Okay.
No, Guohua, we
Yeah.
have lack of time, which means we are going to finish the connection now, and we don't see the next video. We thank you very much for your contribution. And now we are going to proceed in our program in Morocco. Okay?
Okay.
Okay?
Okay.
Yeah. Thank you very much and
Thank you,
goodbye.
Sven.
Bye bye.
Goodbye. Bye-bye.